Dunn, who's a wonderful developmental person who's at South Carolina, at Charlestown, where Dr. Shirali used to be, but I don't think Dr. Shirali ever worked directly with Andy. Anyway, as you probably know, when the heart tube originally develops, there is a connection between the heart tube and the what will be the mediastinum or prepharyngeal mesenchyme back here. This is the foregut, what will develop into the pharynx. And so there's a connection between the heart tube called the dorsal mesocardium. And the dorsal mesocardium is a pathway for cells to enter the heart tube for growth of the heart tube. Now, as the heart tube starts to loop and folds anteriorly to form the original C loop, much of the dorsal mesocardium breaks down, but it persists at the venous or atrial end and at the arterial end, where cells can continue to enter into the heart tube to elongate it. And so what we want to look at is the venous end back here. And you remember yesterday we talked about some development of the atrial septum. We'll talk just briefly about that as well. But anyway, the dorsal mesocardium back here, where the heart tube is still attached to the prepharyngeal mesoderm here, looks like this. There's a pathway for cells here to enter into the heart for continued growth. And there are two ridges, the left and right pulmonary ridges, which are the lateral confines of the dorsal mesocardium, the lateral extent of where it connects with the heart. And in between there is where the pulmonary vein will develop, in between these two little ridges. And if we start at a section that's rather cranial here in the embryo, this is the primary atrial septum, or septum primum, that we've talked about before when we were talking about the atria, growing down out of the posterior superior wall of the common atrial tube here to begin to divide the atrium. And here you can see it coming down. Now, endothelial cells, or progeny of endothelial cells in these cuts, are all stained this sort of greenish blue. So we can follow cells that either used to be endothelial cells and became mesenchymal cells here in the cap of the primary atrial septum, or as we see developing out here in the pulmonary vein, that still are endothelial cells. And as we follow this down, you can see this primary atrial septum is right above the right pulmonary ridge. And the right pulmonary ridge enlarges compared to the left. The left actually sort of disappears after a little while, but the right one enlarges and becomes what's called the dorsal mesenchymal protrusion. It's also known as the spina vestibuli, or vestibular spine, or atrial spine, or a number of other names. But it begins to grow, and this will form part of the interatrial septum as well. This little cartoon over here sort of shows what's happening in an overall global sense. You see here septum primum. The atrial wall is up here. Septum primum is growing down toward the two main endocardial cushions. This atrial spine, or the dorsal mesenchymal protrusion, is growing in from the posterior aspect back here into the floor of the atrium, and it's going to join up with the inferior cushion. Septum primum is going to join up with the superior cushion, and then these will all just sort of continue to grow together and close the primary interatrial foramen here, or ostium primum, to allow ostium secundum, which is developed up here in the substance of septum primum, to be the communication between the atria. Now, the reason for mentioning that is that this is the dorsal mesenchymal protrusion. This thing labeled up here atrial spine is here. It's continuous with the right pulmonary ridge. And this enlarges and will continue to grow down and join the inferior cushion. This is the inferior AV cushion down here just below it, and it will join with it. And you can see that the pulmonary vein, which is developing over here just to the left of this ridge, will then be in the left atrium. This will form the base of the interatrial septum. Septum primum, which is just above this, will form the roof of the interatrial septum up here. And so the pulmonary vein then gets confined to the left atrium, and the systemic veins, which are developing over here, these are the venous valves that are developing here in the right atrium, where sinus venosus connects with the right atrium, will be on the right side. And here you can see little green strands back here within the dorsal mesocardium in this prepharyngeal mesoderm, and these are endothelial cells that are the pulmonary vein that's developing. It doesn't, pulmonary veins and arteries don't sort of, grow out looking for something, looking for the lungs or this kind of thing. No, that isn't what happens at all. It all develops right in situ, right where it is. And if you look at these next pictures, again, this is Andy Vessel's work, you can see how close the lung buds are. See, here's this developing pulmonary vein here. Here's the dorsal mesenchymal protrusion that's coming into the atria to form the base of the atrial septum. And here you see the pulmonary veins developing. Here, these are the lung buds. They're just microns away. I mean, they're just very close to where all this is happening. So it can just happen in situ here. And there's a single pulmonary vein initially that grows into the atrium. And then we'll see that most of this common pulmonary vein and a little bit of the branches will actually become incorporated into the left atrium. This is a very old diagram by Buell. This was published in 1922 from some work that was done then on embryology, and it's still quite accurate right now. And these are just beautiful diagrams. Here you can see the arches developing, the aortic arches developing. Here's arch 2, 3, and 4 is just appearing. We don't have a 6th arch yet, or the pulmonary arch, what will become the ductus, but we already do have branch pulmonary arteries. You can see them growing out of the posterior aspect of the aortic sac. And there's one on each side. This is the developing lung bud. Here's the foregut. This will develop into the pharynx and esophagus, and this will develop into the larynx, trachea, and bronchi. These are the lung buds right here. This is the venous system, and here's the arterial system. This is the looping heart. It still hasn't begun, it hasn't completed looping yet. This all occurs relatively early. But what you see developing around not only the foregut and the lung, but we would see if it showed on here the neural tube, which is developing up here, there are vascular plexuses developing around all of these little organs to supply them as they develop. And the same thing is developing here around the lung bud. The pulmonary arteries are coming from the aortic sac to provide an arterial inflow into the lungs, which will become the pulmonary arteries. And this is the common pulmonary vein here that's developing on the other end, on the venous end of things, to drain blood back from the lung bud into the developing atria back here. But notice that there are many connections between this little plexus around the lung bud, and this is the anterior cardinal vein here. This is the splanchnic plexus that's developing back here around the gut, which will be things like the umbilical vein or the portal vein that will develop from all of this. So you can see how connections could develop from this venous plexus, and do develop, to all of these systemic venous structures that are in the area. And in fact, if something happens to the common pulmonary vein or to a portion of it, these connections that develop here with the various veins that are in the area can persist, and that's how we can have either totally anomalous or partially anomalous pulmonary venous connection. So that's basically the concept here. This plexus develops. There are connections with systemic veins in the area. Then this endothelial strand that connects these to the back of the atrium through the dorsal mesocardium luminizes, forms the pulmonary vein. We begin to have blood flow in this direction, and these connections then tend to disappear, probably because more flow is going through the common pulmonary vein, less through these. Maybe that's the reason. And they begin to disappear. And so then much of this gets incorporated into the back of the left atrium. And if that doesn't happen, and these persist, then we have the various patterns of anomalous pulmonary venous connection that we'll see. So there are basically two types of anomalous pulmonary venous connection that we see. One is partially anomalous pulmonary venous connection, in which some, but not all, of the pulmonary veins connect either to the right atrium or to one of its venous tributaries, either the inferior vena cava, superior vena cava, or some tributary or coronary sinus. And so what we have then is say in this case, this is a left superior pulmonary vein draining to the innominate vein, which is a relatively frequent type of partially anomalous pulmonary venous connection. Here you have oxygenated blood coming into the innominate vein, mixing here and increasing a little bit the saturation of blood in the right side of the heart. It may not be very much if this is a small vein, either a lobar vein or even a sublobar vein that can connect this way. So this is a pre-tricuspid left to right shunt of variable size. Sometimes these are quite small, sometimes they're not so small. It can produce a right ventricular volume overload, just like an atrial septal defect. The physiology is rather similar. There can be variable pulmonary hypertension, but mostly this happens in partial veins at an older age. We've seen a couple of patients who have had isolated, anomalously draining single veins present in their 30s and 40s with right heart failure and pulmonary hypertension. But I think this is not very common, but it can happen. And variable pulmonary vein obstruction, sometimes these veins can become obstructed and cause, usually what happens then is that there are collaterals that develop within the lung that drain that segment through other veins. So here's an example of this. Here are the inferior left veins here coming back to the left atrium, and here's the superior left vein here. There's the pulmonary artery, and just above it is the small left pulmonary vein up here draining the upper portion of the left lung here. And it'll come to the innominate vein, which we see here. Here's the right jugular, left jugular, and here's the left, or the right superior vena cava draining into the right atrium here. So this is a rather frequent type of anomalous pulmonary venous connection that we see, the left upper vein draining into the innominate vein. There are many other types. You can have, all of one lung, for example, draining to the coronary sinus, or all of one lung draining below the diaphragm, or a number of other patterns of partially anomalous pulmonary venous connection. One of the ones that I want to tell you about specifically, here's one that we saw yesterday, and this is the foraminal valley here. The coronary sinus is down here, so we're looking in the right atrium. Here's the appendage part up here, and notice that these are the right upper, there's the superior vena cava, and these are the right upper pulmonary veins. This is a patient who has a sinus venosus defect like we saw yesterday. And so these are right upper pulmonary veins here draining into the base of the superior vena cava. Occasionally this can happen, and the defect down here, what really is the mouth of the pulmonary vein into the left atrium, is atretic. And so you have just these veins draining to the superior vena cava. That's one of the other patterns that we see. Scimitar syndrome is a named type of partially anomalous pulmonary venous connection that we see, and has several components. Some or all of the right veins drain to the inferior vena cava near its junction with the right atrium. There's usually right lung hypoplasia and dysplasia often. There's often dextroposition of the heart. The heart's moved over into the right chest because of the small right lung. It just moves into the right chest as the left lung expands to take over the function of it. And sometimes there is a sequestration, or a part of particularly the base of the right lung that isn't connected with the tracheobronchial tree and is supplied by a systemic artery from the descending aorta. So here's an example of scimitar, and here's the left lung, which is normal. And this is the very hypoplastic, dysplastic right lung that you see on the other side. Here are the aorta and pulmonary artery here in the front. This is the right atrial appendage here. And looking inside, we see the inferior vena cava here, and this is the inferior pulmonary vein here on the right side that drains to the inferior vena cava. There you see it right there. And so there's the right inferior vein to the inferior vena cava. And you see there is a right superior vein here that drains separately. But this is just a fibrous cord, as sometimes happens here. This has become completely obstructed. There's no lumen in this vein at all. So where it exactly went is hard to tell. Whether it drained normally to the left atrium or not is a little bit hard to tell. Here's the left atrium here, left atrial appendage, and these are the left pulmonary veins here draining normally into a rather small left atrium because the right pulmonary veins are no longer associated with it. So that's Scimitar syndrome. This is another example of Scimitar without the right lung hypoplasia, but with a sequestration artery here. Here you see this artery coming from the aorta, the descending aorta below the diaphragm, which is the typical place where sequestration arteries come from, and it then continues up and supplies one or more segments of the right lung in this case. There you can see it coming up to the right lung. So that's the sequestration component. It isn't always present, but it often is with Scimitar syndrome. Now, totally anomalous pulmonary venous connection means that all of the pulmonary veins connect anomalously either to the right atrium or one of its venous tributaries. Again, I'm using the definitions that our surgical colleagues have so kindly provided for us of congenital heart disease. And here's what happens here is that all of the pulmonary venous return, in this case, this just shows an example of a subdiaphragmatic or one below the diaphragm, usually to the portal vein or portal sinus, coming down here into the inferior vena cava circuit. And then you can see that there is basically common mixing in the atrium as there's no pulmonary vein returning to the left atrium. So all the systemic venous return and all the pulmonary venous return comes to the right atrium. There's mixing here. Blood flow goes from right to left across the interatrial septum because there's no other way to get blood into the left heart. And then there's relatively similar saturation around the various parts of the heart. It isn't always exactly the same because there can be a bit of streaming because of the position of the veins, but it's relatively uniform around the heart and less than normal, of course. So this is a common mixing lesion. It's a right ventricular volume overload because there's extra blood, pulmonary venous blood, coming back. Some of it goes to the right ventricle, some of it crosses the atrial septum and goes to the left ventricle, but generally there is a much larger right ventricle and smaller left ventricle. If there's pulmonary hypertension, the right ventricle is also quite hypertrophied. There often is pulmonary hypertension, particularly if there's obstruction along the pathway of the venous return. Variable cyanosis, for example, babies with veins to the coronary sinus may be only mildly cyanotic because there's a lot of pulmonary blood flow, there's good mixing, and these babies may have a saturation in the high 80s, for example. And variable pulmonary vein obstruction. If this goes to the portal sinus, then unless there's an abnormal connection between the portal vein and the inferior vena cava, all of the blood has to traverse the liver sinusoids. And so this is a mechanism for pulmonary vein obstruction there, even though the pathway itself may not be terribly narrow anywhere. Sometimes it is, but it doesn't have to be. The fact that the blood has to traverse the liver sinusoids means that there's some obstruction. Ones that go above to the innominate vein often get trapped between the pulmonary artery and the bronchus on the left side and can cause discrete obstruction at that point. So here's an example of infracardiac total veins. Here you see the aorta here, the pulmonary artery, right atrial appendage, right lung, left lung in this case. So we open the heart. Here's the right atrium here, inferior vena cava, tricuspid valve. There's the foramen ovale that has to be open. Blood flow goes from right to left across that. Here's our right ventricle here, the atrial appendage up here, tricuspid valve annulus. And on the left side, you can see that the left ventricle looks quite a bit smaller than the right ventricle. This is fairly typical. And here's our left atrium with the communication with the right atrium here, the foramen ovale here, which is open. And you don't see any other venous structures coming into the back of this atrium. It's just blind in the back. Now we're going to turn the specimen over. So now we're looking from the back. This is the patient's left. This is the patient's right. And here you see this venous channel here. These are the pulmonary veins here. This is the left pulmonary vein. This is one of them. There's the upper vein there. Here's the lower vein here. They come together. Here's the right upper, right lower, and they come into this confluence. And then there's a vertical channel that goes below the diaphragm, and in this case joins the portal sinus down here within the liver. And here you can see this. We're in the inferior vena cava. There is a little connection here between. This is probably a residual part of the ductus venosus between the portal sinus and the inferior vena cava here within the liver. So this is a fairly typical appearance of subdiaphragmatic total veins. The veins come together up here almost like a T or a Y with the individual veins draining into the top of this confluence, and then sometimes there'll be another one. We'll see, I think, on another example, there can be one a little bit lower down. Here's one other example. Notice that this patient has dextrocardia. This is probably a patient with heterotaxy syndrome. Total veins certainly is very common in heterotaxy. Here you see a big aorta over here and a small pulmonary artery, so that sort of goes along with that. There's a reasonable sized left ventricle here. There's the left ventricular septal surface, papillary muscles there. Here's the right ventricle. Both great arteries, the pulmonary artery here and the aorta here, come from the right ventricle. So this is double outlet right ventricle. And here you can see the inferior vena cava going down from the atrium down into the liver. And again, as we turn this over, you see the venous connections here. Here are the left upper veins here. Here are the right upper veins over here coming into the top of this confluence. But then there's a lower vein here on the left that comes in quite low down. And this is something to be aware of and to look carefully for with echocardiography, because sometimes this vein can be just above the diaphragm from either side, really. And so it's important to look carefully all along the course of the vertical vein here to see other veins that may be draining in, because the surgeons need to know exactly where the veins are so that they don't inadvertently exclude one into the systemic venous circuit. So this is, again, a fairly typical pattern with having one of the veins often on the left side, I'm sorry, on the right side here, coming in quite low into the vertical connector. We can also see veins to the coronary sinus. Here's the superior vena cava, the aorta and pulmonary artery. And here there's a very large right atrial appendage here. Here's our tricuspid valve, right ventricle. And you can see that this is a very capacious appendage up here. And this is the foraminal valley there. And the coronary sinus is going to be just below that right here. This is an enlarged mouth of a coronary sinus here. It's the same size in this case as the foraminal valley. And here's the pulmonary outflow tract, which is again quite large. The right ventricle here is dilated. It's relatively thin-walled. It's not very hypertrophied because veins to the coronary sinus aren't usually obstructed. They can be, but they aren't usually. Here's our left ventricle, which is a little bit smaller than the right. And here's the left atrium here. And again, we don't see any veins coming into the back of this left atrium. So here are the, we've just flipped the heart up. So these are the left veins and these are the right veins coming into the back into the coronary sinus. So if we look inside, there's the ostium of coronary sinus into right atrium. And here are the left veins and here are right veins here. And one of them has been divided here and put back together with a suture. A piece of it, I guess, was sent for histology. And so you can see the coronary sinus coming into the back of the atrium with the veins just coming into the coronary sinus and not directly into the atrium. Supracardiac total veins tend to go to the innominate vein. Here you see the superior vena cava, a large innominate vein here running in front of the aorta and pulmonary trunk. And then here's the vertical connector on the left side of the pulmonary trunk. And again, a very large right atrium, right ventricle. Here we see the foraminal valley, appendage up here. Here's the tricuspid valve into the right ventricle. A very large ventricle. This is a little bit more hypertrophied, but not excessively so. Pulmonary valve up here, the outflow tract is quite large. And notice how much smaller the left ventricle appears in this baby. And this is quite typical, again, because of the right ventricular volume overload. Here's the foramen ovale right here. Here's the left atrium. And again, you don't see any evidence of pulmonary veins coming into the back of this atrium. The left atrium tends to be quite small in babies with anomalous pulmonary venous connection because it's missing the pulmonary venous component. And then we just flip the heart up, so this is still right and this is still left as though we're looking at the patient. And here you see there's a rather horizontal connector here, and we have upper and lower veins on the right. And supracardiac veins really look like this basically all the time. That you have the two right veins forming a little Y here into the connector. Then you have a left vein that comes in just at the angle over here, and often just a little bit higher up is an upper vein on the left that comes in just before the vertical connector goes up around the pulmonary trunk here to get up to the innominate vein. And you can imagine if this passed between the pulmonary artery and the bronchus over here, how it could become obstructed. And so here we see the connector coming up, and here's the innominate vein, and then the superior vena cava coming back into the right atrium on the other side. So the outcome, 10% or so of babies, not heterotaxy, but with other types of pulmonary venous connection anomalies, develop some kind of pulmonary vein stenosis after repair. Pulmonary vein size is relatively predictive of this, and babies with mixed drainage where some of the veins go one place and some go another, have a worse outcome. As you can see over here, and this is a biventricular repair, and babies who undergo a single ventricle repair with total anomalous pulmonary venous connection really have a very poor prognosis. This is work that Kathy Jenkins did with us at Children's some years ago, looking at the relationship between pulmonary vein size and body surface area here, and predicting patients with larger pulmonary veins here in dark survived. The ones with smaller pulmonary veins over here tended to develop pulmonary vein stenosis and die. So pulmonary vein size seems to be important. And one of the techniques that's now been developed to try to treat either pulmonary vein stenosis or to treat anomalous pulmonary veins primarily to avoid developing stenosis, particularly in mixed type venous drainage, is what's been called a sutureless technique. Now, it really isn't sutureless, but what it means is that there are no sutures that are actually placed into the pulmonary veins. So the pulmonary veins are here just behind in the pericardium here, right inside the pericardial cavity just behind the left atrium. And so what happens then is that the veins are just opened. The top of the pulmonary veins here, it's unroofed into this little, what's going to become a little well or a little cavity back here behind the left atrium that is walled with pericardium. And the left atrium is up here, an incision is made in the left atrium, and then the pericardium around the pulmonary veins is sewn to this opening in the back of the left atrium. And this seems to be making some difference in the outcome, particularly in complex or mixed types of pulmonary venous drainage, or in patients who have had surgery for pulmonary vein anomalies who then develop obstruction. This, in some of those babies, this can actually make a difference and improve the situation. So that's the story about pulmonary vein development and anomalous pulmonary venous connection. Question? Sure. While they're setting up, of course. Sure.
One is, you talked about, my understanding from the morphological point of view was that the left atrium, the pulmonary veins contribute to the size of the left atrium.
Correct.
Is that correct?
Yes.
It isn't just hemodynamic effect?
No, they really do contribute. In fact, if you do histology of the left atrium, in a normal left atrium, you'll see that the dome, the back wall of the left atrium has more vascular characteristics. Okay. There is myocardium because the pulmonary vein is myocardial, but
Well, the pulmonary venous drainage anomaly is really one of the most interesting of all congenital heart lesions when it comes to physiology. It's really quite fascinating because there's so many potential variations in the physiology that you can get. And I'll talk very briefly about partial pulmonary venous drainage connection, but I'm going to concentrate on the total veins. The other very important thing about total pulmonary venous drainage anomaly is that it's the diagnosis which is most commonly missed in the newborn, especially because neonatologists never think about it in a baby with respiratory distress. So it's really very commonly missed. So for these reasons, it's a very important lesion. Now, as far as partial anomalous pulmonary venous connection is concerned, most of them, there's only one vein that's abnormally connected. You may get more veins that are abnormally connected, but most of the time it's one vein. Most commonly, it's in association with the sinus venosus defect, where the right upper and sometimes right middle pulmonary veins join just at where the superior vena cava comes into the right atrium and drain into the right atrium. So most of these partial veins are associated with secundum atrial septal defects. It's unusual that you don't have a secundum atrial defect, and all that happens really is that it contributes to the left to right shunt that's usually present with the atrial septal defect. When there's no atrial septal defect, there's one particular lesion that occurs, and that is the drainage, abnormal drainage of the lower right pulmonary vein that's associated with sequestration of the lung. The right lower pulmonary vein and sometimes the middle vein drain directly into the inferior vena cava, and the lung lobe is sequestrated, and the arterial supply comes from the aorta, from the infradiaphragmatic portion of the aorta. Now, the interesting question is what happens in the fetus with partial anomalous pulmonary venous drainage? Well, not very much happens. If you think about it, it's interesting that in the fetus, first of all, unlike in postnatally, where the pulmonary venous blood is well oxygenated, in the fetus, the blood in the pulmonary vein is really venous blood, venous in terms of its saturation, because the blood going into the pulmonary artery is relatively poorly saturated. The lung takes up a small amount of oxygen, so that the pulmonary venous blood has a slightly lower saturation than pulmonary arterial blood. So this blood is not well oxygenated in the fetus. And it really doesn't do much because pulmonary blood flow is low in the fetus, the total volume of blood that passes through that vein is really very small, and it really doesn't have much contribution to anything. The one interesting thing about this is when you consider the fact that normally in the fetus, the right atrial pressure is slightly higher than the left atrial pressure because blood is flowing in the fetus from right to left through the foramen. And so that if the vein drains into the right atrium, it means that it has a slightly higher outflow pressure than it would have if it were draining into the left atrium, and this may further limit the flow that occurs in that pulmonary vein. But it's not a particularly important issue. Now, what happens postnatally with partial pulmonary venous drainage anomaly? Well, the situation is reversed completely, because here now, in the postnatally, the left atrial pressure is normally higher, so that the outflow pressure if the pulmonary vein were draining into the left atrium, would be pretty low. Pretty high comparatively. But since it's draining into the right atrium, in the postnatally, right atrial pressure is lower, so that the flow through that vein is higher somewhat than if it had been draining into the left atrium. And what happens is this adds to the left to right shunt, which is usually present from the atrial septal defect. But again, these veins in general do not cause much in the way of hemodynamic disturbance. And in some, a big question arises whether they should be corrected or not. Some of them may cause some difficulty, but many of them never cause any problem at all. So let's now go on to the issue of total venous, anomalous pulmonary venous connection. And I won't do much on this because these have been discussed before, but the drainage may be infradiaphragmatic, and when we say infradiaphragmatic, the vast majority of them go to the left portal vein. Sometimes they go to the right, but that's quite unusual. And it's really very important in terms of what the dynamics of the circulation are. The ones that go supradiaphragmatically, the commonest supradiaphragmatic is through a vertical vein to the left innominate vein and through the superior vena cava and then into the right atrium. Coronary sinus drainage, you've seen, is also another site they may drain. And then sometimes they drain directly across, behind the heart, into either the azygos vein or the superior vena cava directly, right near where the azygos joins the superior vena cava. This type of drainage is most commonly seen in right atrial isomerism, in heterotaxy. And it's an important one to know about and to think about, as I'll mention later. As was mentioned, very often these veins are obstructed. And the obstruction varies as to where it might be. With infradiaphragmatic drainage, the obstruction may be because the whole common channel is narrow. There has been described constriction in the region where it passes through the diaphragm, but by far the majority of them are where it enters the portal vein, and then another site of obstruction can be the ductus venosus. We'll talk about that later. In the supradiaphragmatic venous return, there may be compression of the vertical vein where it passes behind the left pulmonary artery, but probably the commonest type of obstruction is where there's no localized obstruction, but where the whole vein is narrow, and that provides some degree of obstruction. And then we mentioned this narrow, where in the drainage with right atrial isomerism, there may be an obstruction because the veins are small. Well, now, I'm going to go back again to this diagram of fetal physiology, because this is really fundamental to understanding what happens with total pulmonary venous drainage anomaly in the fetus. Now, in the fetus, I mentioned to you, the pulmonary arterial PO2 is low. We've measured it in the sheep fetus, it's about 18 millimeters of mercury. Pulmonary venous PO2 is even lower because there's been some oxygen taken up. So the oxygen saturation of pulmonary arterial blood is about 50%. Oxygen saturation of pulmonary venous blood, which has a PO2 of about 16, is about 45, 46%. So it's really quite low. Now, with the infradiaphragmatic drainage, if all the veins drain into the left portal vein. Now, I should just mention, in the fetus, the umbilical vein drains up into this portal sinus region. The left portal veins come off before the ductus venosus. And this is why the blood distributed to the left lobe of the liver is pure umbilical venous blood. There's no other venous blood that goes to the left lobe of the liver. Then this blood goes across this, we've called this the arcuate branch of the portal system, and then it goes across to the right where it's joined by the portal vein coming from the gut. And then there are branches to the right lobe of the liver. Now, this blood, because it's portal venous blood, has an oxygen saturation of about 35 to 40%. Oxygen saturation of umbilical venous blood is about 85%. So there's a vast difference in the blood that goes to the right lobe versus the left lobe of the liver. Now, the other important thing is the drainage of this blood from the liver. A certain proportion of blood goes directly through, from the umbilical vein, goes directly through the ductus venosus. Now, in the sheep fetus, this is about half of the umbilical venous return. In the human, it's only about 25% of umbilical venous return. And the other thing I've mentioned to you before, in the sheep, the umbilical venous flow is about 40% of total output of the heart. In the human, it's only about 25 to 30%. So umbilical blood flow in the human is relatively low. I don't have time to go into, it's an interesting issue as to why this is so, but it is much lower than in other species. But what happens is that the blood from the left hepatic vein and from the ductus venosus is preferentially directed through the foramina veli into the left atrium. We mentioned this repeatedly, that the left atrium in the fetus is supplied with pretty well oxygenated blood. Whereas if you look at what happens with the right hepatic vein and the distal inferior vena cava, with both of which have low saturations, the right hepatic venous saturation is about 65%. It's higher because of some umbilical venous blood going to the right lobe of the liver. But this blood from the distal inferior vena cava and from the right hepatic vein are preferentially directed through the tricuspid valve. They don't go across to the left side of the heart, so they go to the right atrium and right ventricle, and then out the pulmonary artery. And of course, from the pulmonary artery, as we know, a lot of that blood ejected by the right ventricle will go down the ductus through the ductus down to the descending aorta. Now, with this background, it's really important to know where these veins, if the pulmonary veins are draining anomalously, it's important to know where they're draining, because what's going to happen to their distribution is going to depend on where in the system they drain. So the other point, I'll just go back. The other point I want to make is I mentioned that the right hepatic venous and distal inferior vena cava blood go preferentially through the tricuspid valve. Also, all the blood coming back to the heart through the superior vena cava is directed through the tricuspid valve. None of it goes through the foramen. So that you can see that the fetal heart is specially designed then to take poorly oxygenated blood into the right side of the heart and send some of it to the lungs, some of it to the ductus down to the placenta to be oxygenated. Whereas the well-oxygenated blood is preferentially directed into the left side to provide oxygen, high oxygen blood to the brain and the heart. So that's the way in which the fetal heart is functioning. Now, if you have a supradiaphragmatic drainage of all the pulmonary veins, what would happen? Well, that blood would all go through the tricuspid valve. And what happens? Since pulmonary venous blood is poorly oxygenated, it would add to the low oxygen blood going to the right side of the heart, but it would remove a fair amount of low oxygen blood from draining where it would drain normally into the left atrium. It would not drain there anymore. So the blood going to the left atrium would be only the well-oxygenated blood coming from the left hepatic vein and the ductus venosus. So that what this does is it enhances the oxygen saturation of blood being ejected by the left side of the heart, because you're removing the poorly oxygenated pulmonary venous blood from the left side. So you get now an interesting situation where normally there's a somewhat higher saturation in ascending aorta and carotid vessels versus the descending aorta in the fetus. In this situation, with supradiaphragmatic drainage, you get an enhancement of that. So the oxygen saturation of aortic blood is considerably higher, ascending aortic blood is considerably higher than descending aortic blood. Now, one of the, I think we mentioned this. I'm sorry. Yeah, wrong way. Here we go. Okay. Okay, let's go one more. That's where we were. Sorry. Now, what happens with the blood in total pulmonary venous drainage anomaly, if there is drainage into the infradiaphragmatic portion, there will be an extra volume of blood going through the foramina veli into the left side of the heart. So the left side of the heart will get a reasonably good supply of blood. On the other hand, if the drainage is from the supradiaphragmatic area, so that either coronary sinus or superior vena caval drainage, that blood will now all go to the superior vena cava here and will be presented to the right side, and the amount of blood going into the left side would be reduced because there's no pulmonary venous blood coming into the left atrium anymore. So the total volume of blood delivered to the left ventricle would be considerably reduced. And this accounts for the fact that the left ventricle and left atrium as well are quite small in total pulmonary venous drainage anomaly, particularly when it's supradiaphragmatic. Now, one of the issues about that is if in the fetus, if left ventricular output is low because the volume returning to the left atrium and left ventricle is low. This would mean that ascending aortic flow is reduced, and because of that, probably flow across the aortic isthmus would be reduced. And this probably is an explanation for the fact that in total pulmonary venous drainage anomaly, particularly those with supradiaphragmatic drainage, there is an incidence of narrow isthmus and of coarctation of the aorta. I'll describe to you later, tomorrow when we talk about coarctation, the concept of how coarctation may develop in relation to blood flow changes. So this is an interesting issue then that occurs in supradiaphragmatic drainage. And the fact that all the blood returns to the right side enhances the likelihood that you may get coarctation developing based on the principle that has been discussed by Hutchins. I'll talk about that tomorrow. But I think it's an interesting association that occurs in these patients. Now, it's interesting that obstruction of pulmonary venous drainage in the fetus is not common. And the reason, of course, is that even if there is some degree of obstruction, or if the common channel returning to the heart is small, narrow, the total blood flow is low. So that even if there's some obstruction, there is not much in the way of physiologic obstruction, because the flow is so low, and with low flow, you don't get obstruction. So that it's unusual to have significant obstruction in the fetus. It can occur though, and when it does occur, what you get, of course, is what you get postnatally, and that is pulmonary edema. And pulmonary lymphedema is one of the things that's associated with total pulmonary venous drainage obstruction, with the obstruction of total venous drainage in the fetus. When they develop lymphedema of the lung, it results in a very difficult resuscitation at birth because the lungs cannot be expanded. So these babies who have lymphedema as a result of pulmonary venous obstruction rarely survive. Okay, now let's talk about what happens after birth. Now, if you think about what happens in the postnatal period, now all of a sudden the lungs are oxygenated, and the oxygen saturation in pulmonary veins changes completely, because now pulmonary venous blood is very well oxygen saturated, 95 to 100% within minutes after birth. So now you have to take into consideration what the impact will be of the drainage of this well-oxygenated blood to different parts of the circulation. And what happens is that as pulmonary blood flow increases, remember that this is one of the lesions in which, as was described earlier, in which there's total admixture of pulmonary and systemic venous blood. So what determines the oxygen saturation of the blood delivered to the body? It's the pulmonary to systemic blood flow ratio. So the higher the pulmonary blood flow, the higher will be the mixed oxygen saturation of the blood. So if you have a pulmonary blood flow which is twice systemic blood flow, you will have a saturation which is probably about 75 to 80%. If you have a pulmonary blood flow which is 3 times to 4 times systemic blood flow, you may have a saturation up to 80 to 90%. So that the pulmonary blood flow becomes a crucial factor in determining what the oxygenation of the baby is. And it's really, in this condition, it's predominantly pulmonary blood flow rather than systemic blood flow which determines the final saturation. There are certain situations, though, in which systemic blood flow may be reduced also, which would then also exaggerate the pulmonary systemic blood flow ratio. That is quite unusual in the early neonatal period, and it occurs if the foramen ovale is obstructed for any reason, so that blood cannot get from the right atrium into the left atrium to be distributed to the systemic circulation. But that's unusual at this period. It may occur later. We'll talk about that. Now, one of the things that we have to consider is the role of the ductus arteriosus. We know that the ductus is open in the early neonatal period, and the shunting of the ductus will create differences in oxygen saturation between the upper and lower body. And this is really very important in diagnosis in the newborn. And I'll mention what happens with these lesions in terms of the differential saturation between the upper and lower body, and is different with different drainage. So that when the pulmonary veins are draining to the superior vena cava, what happens is that you get well oxygenated blood going through the superior vena cava and then, of course, across the tricuspid valve into the pulmonary artery, and some of that goes to the descending aorta. So you have this unusual situation then where lower body blood is better saturated than upper body blood. It's one of the few conditions in which, if you measure oxygen saturation of the right arm and the lower limb, you find a higher oxygen saturation in the lower body. So that's total pulmonary venous drainage to supradiaphragmatic, to the superior vena cava or coronary sinus, because coronary sinus blood also goes across the tricuspid valve. So that type of drainage will result in this very interesting diagnostic situation where the lower body saturation is higher than the upper body. There are only three other conditions which produce that. I'll mention those to you later, but it's very interesting. That is very rare and it's very diagnostic. Now, when the drainage is to the left portal vein, which is a common drainage, you now have the interesting situation where the blood, which is well oxygenated, is going to the left portal vein, comes out through the liver, through the left hepatic vein, and then preferentially goes across the foramen. So it goes to the left side of the heart. So that means that with infradiaphragmatic drainage to the left portal vein, the blood going to the upper body has a higher oxygen saturation. And the blood going to the lower body is mainly blood which has come from the superior vena cava, which is venous blood, and which goes across into the right side and then through the ductus to the lower body, so the lower body is getting poorly oxygenated blood, the upper body is getting well oxygenated blood, as usually occurs in the normal. But you see there's this big difference in saturation depending on, related to ductus flow patterns, whether the veins drain infradiaphragmatic or supradiaphragmatically. Now, interestingly, it's the vast majority of infradiaphragmatic drainage is to the left portal vein. Occasionally, rarely actually, it may drain over on the right side, where you see where the portal vein connects to that arcuate branch of the umbilical vein. When it connects there, the drainage is into the right lobe of the liver, and when it goes into the right lobe of the liver, the streaming pattern takes it through the tricuspid valve. So if it goes through the tricuspid valve, this well-oxygenated blood would then get to the right ventricle, ductus arteriosus, and lower body, so that if it goes to the right side of the portal venous system, it'll be the same as if it's supradiaphragmatic drainage. And this is what is so fascinating about this condition. It's got these tremendous variations in the flow patterns and in what you find with them. Okay, now I said that the ductus arteriosus is important, and we've mentioned all this, I think. Yeah. Now, the one interest, before we go on to talk about the obstruction, one interesting thing that I'd like to mention is what the role of the ductus arteriosus is. And we'll come to it in more detail in a minute, but I think it's important to recognize that when you have total pulmonary venous drainage anomaly, the volume of pulmonary venous blood returning to the heart is dependent on a number of factors. Obviously, it depends on what pulmonary vascular resistance does. So that if pulmonary vascular resistance is high, pulmonary blood flow will not be increased much. If pulmonary vascular resistance falls dramatically, you will get a high pulmonary blood flow. Now, how does the ductus influence this? Well, the ductus is very important because it will determine what the pulmonary arterial pressure is. If the ductus is wide open, a lot of blood ejected by the right ventricle can go through the ductus down to the descending aorta, and therefore less blood is directed through the lung because of the pressure in the pulmonary artery being essentially decreased by the flow through the ductus. If the ductus closes, however, then you can get an increase in pulmonary arterial pressure and preferential flow through the lung. Now, the impact that this has is that if the ductus is wide open, there will not be as much blood going through the lung. Therefore, you will decrease the likelihood of having severe pulmonary edema, especially with obstruction, because pulmonary edema occurs when pulmonary venous pressure goes up. If flow is reduced, pulmonary venous pressure will not go up as much, so that you will get less likelihood of pulmonary edema. On the other hand, while the ductus is open, you'll be shunting a lot of poorly oxygenated blood, potentially, across the ductus, and therefore oxygen saturation of blood will be relatively low. Now, if you close the ductus, you increase pulmonary blood flow, thereby improving the pulmonary to systemic blood flow ratio, increase oxygen saturation of the peripheral arterial blood, but get more likelihood of pulmonary edema because you now have more pulmonary blood flow if there's obstruction. So I think it's important to recognize all these interrelated phenomena that occur and why the clinical picture in these babies is so complex and so variable. So let's talk about obstruction now. Now, the obstruction, the one we think of most is the one with severe obstruction. And that's the obstruction that occurs in... Am I going on too long, Norman?
No. Takes the whole day.
The commonest thing we think about with obstruction is the obstruction that occurs in the baby in the newborn period, in which it presents acutely with severe pulmonary edema, and we all know the picture. But obstruction may also occur in usually presenting later after birth, and it's either mild or moderate. And we'll talk about that in a moment. Now, in severe obstruction, as I mentioned, it may not be evident before birth because pulmonary blood flow is low. As soon as you get the increase in pulmonary blood flow after birth, though, it now becomes manifest. And the elevated pulmonary venous pressure results in increased fluid in the lung alveoli and hypoxemia and pulmonary vasoconstriction and all these bad things that happen. Now, we tend to immediately give oxygen to these babies. That's the first response we have, is when we see a baby in distress, is we give oxygen. So the question is, what is the potential effect of oxygen in these babies? Well, if it improves oxygenation, it could do two things. It could constrict the ductus. And as I mentioned earlier, if you constrict the ductus, you tend to increase pulmonary blood flow and make pulmonary edema worse. So you may not get that much benefit from oxygen in these babies because of that. The other thing that we tend to do is to give prostaglandin. And again, although it's not a common phenomenon, it is possible that you could make the situation worse because by giving prostaglandin, what you do, you dilate the ductus, reduce pulmonary arterial pressure, and therefore reduce pulmonary blood flow. So all these things have potential benefits, but also potential adverse effects. I just want to mention very briefly the role of the ductus venosus. We mentioned that when the drainage is to the left portal system, that the blood then has to go, if the veins are draining into the portal vein here, the blood has to go to get back to the heart, either through the ductus venosus or through the hepatic circulation. And the ductus venosus, it would be a useful bypass to limit obstruction, because if the veins are not obstructed proximal to this, the ductus venosus could impose, if it constricts, could impose a restriction to flow, and therefore, when the ductus closes, it could raise pulmonary venous pressure and cause pulmonary edema. Now, in most babies, the ductus is closed within about 7 days. The ductus venosus is closed within 7 days after birth. But in some of these babies with total pulmonary venous drainage anomaly, the ductus may stay open for as long as 3 months after birth. And a few babies have been reported who didn't get evidence of pulmonary venous obstruction, who'd had total pulmonary venous drainage below the diaphragm to the left side of the portal system, and who did not get into any problem until they were 2 to 3 months of age, when the ductus venosus closed. So it's possible that the ductus venosus can provide a temporary bypass in these patients. The other important thing to remember about the drainage to the portal system is that the blood flow, if the ductus venosus closes, everything then has to go through the hepatic microcirculation. Now, it may be that the blood flow through the hepatic microcirculation is adequate to keep the baby reasonably comfortable. But feeding has a tremendous impact on this, because when the baby is fed, intestinal blood flow increases dramatically, really enormous increase in intestinal blood flow. That all has to go through the liver to get back to heart. So you're now competing in the hepatic microcirculation for flow from the gastrointestinal tract and flow from the pulmonary veins, and pulmonary venous pressure goes up, and you may then get symptoms due to pulmonary edema. And that's an important thing to recognize. And sometimes the symptoms of severe pulmonary distress develop after feeding in these babies. I think I'm going to stop there because I've been talking enough. Thank you.
I'd be glad to waive all of my time so Dr. Rudolph can continue talking. One of the great pleasures of having a conference like this is that as a participant on the giving side, I get also to listen to everybody else talking. And certainly it's quite stimulating for me to have listened to all of my colleagues, Stephen, Abe, Dr. Girish Shirali and Dr. Karen Hasbani. Is that okay? Describing the excellent findings that they've shown us on a variety of these conditions, and how wonderful it is to have the opportunity to sit and learn about things that one obviously didn't concentrate on for a long time, and broaden one's own horizons on these issues. I'm just trying to find my my talk. It's not that one. Oh, it's this one. So now you're going to have to listen to boring old me, and I'm going to bring you back to earth. So let's just look at total and partial veins. And as opposed to my colleagues, I'm going to do it the other way around. I'm going to talk about total veins first as a diagnostic phenomenon with ultrasound. And as many types of total veins are of the fourth type, which is mixed venous drainage, where some goes one way to some part of the circulation and some goes the other way. By the time we get to talk about partial anomalous pulmonary venous return, we will have seen all of these issues in the different kinds of totally anomalous pulmonary venous return. So they vary in their clinical presentation, as Dr. Rudolph has described, from their physiology and the associations that are present. Because of critical issues, it's become one of the conditions that is an emergency in treatment. There is virtually nothing else that has that degree of immediacy of a repair, as opposed to the other conditions where we can temporize even hyperplastic left heart syndrome and transposition for periods of time without considering them to be so important to operate early. In the neonate, as Dr. Rudolph has explained from the lymphedema situation, many of these infants may be indistinguishable from respiratory distress or pulmonary hypertension. And the diagnosis of echocardiography is made as a prelude to placing these patients on ECMO, which led me to use the adage, we always do echo before we do ECMO. And if you look at the alphabet, echo comes before ECMO. So I think that's a good idea, because there have been many patients that have been placed on ECMO Okay, no. And then they found to have total anomalous pulmonary venous return. They die on ECMO too, that's true. But I think that this is certainly an important point, and one of the most important features of being called in for an ECMO study is to make sure that the pulmonary veins are actually draining in the appropriate place, okay? So, I've said that again and again. I think that one of the nice things about looking at this is if you say it enough times, it gets to be considered important. So, yes, I think echo is important before we do ECMO. Okay, and this obstructive pattern is also seen particularly in the asplenia, or otherwise known as Ivermark syndrome or right atrial isomerism. Now, I'll classify them in the commonest way, and that is 1, 2, 3, 4, and I'll even have a 5 in my classification system. 1 is drainage above the heart, and this is the most common, about 60%. 2, to the heart directly, either to the coronary sinus or directly to the right atrium, and then the infradiaphragmatic below the heart. And there are obviously mixed venous drainage, which is type 4, and I actually call veins to the coronary sinus by a separate type. So always think of this. And lesions may be obstructed, as Dr. Rudolph has so eloquently shown us, through different sites, and we'd like to look at some of this in terms of the morphology as well as causing this problem. Well, this is a drawing which is, I guess everybody has these drawings to show that the pulmonary veins as they develop, as Stephen had shown so beautifully, with the junction either to a cardinal or an umbilical vitelline vein, as it's described here, and that the various sites of drainage depend on which of those two primitive systems the veins drain rather than to the left atrium. And I always like to use Dr. Netter's atlas, because everybody has a copy of the atlas, and you can see the various forms of drainage here. But we can see the common type of vertical vein, the infradiaphragmatic drainage, drainage to the coronary sinus, double mixed sorts of drainage, etc., and then this one associated with quarter atriatum. And when you look at the venous drainages, there are variations that occur in mixed drainages which are very important echocardiographically, because these children are critically ill, and catheterization is actually not a great idea in these kids, because you make them much sicker with the giving of the contrast, and contrast is what is important here. So I think that we need to look at the veins, but to look at the veins in a systemic way so that we can see veins and look at them from all sides to see where they're draining. And when you do this, you'll often find surprises. And of course, when the veins drain to different sites, the methods for repair surgically are much different and create a series of problems, and also decrease the prognostic outcome. Now, my favorite thing about looking at echocardiograms is to look at them on a general basis. And here you see a 4-chamber view in a child with a left atrium wall. We can't see pulmonary veins draining to it, but the right side of the heart is large, and this should lead you to suspect that there is some abnormality in the venous drainage. And I think the right-left disproportion that you see here can be seen in a number of different echocardiographic projections. That's parasternal short axis on the top right. Bottom left is a drainage, is a parasternal long axis. And in fact, there's the telltale sign over here. This telltale sign, in fact, you can even see pulmonary veins draining into it from below and above, suggesting that there is a chamber receiving venous structure from the lung behind the heart. Subcostal, coronal, again, you see the vein draining here above the heart. And again, looking subcostally in a subxiphoid short axis, you can see that the left ventricle is proportionately, substantially, and critically smaller than that on the right ventricle. Here's another caveat. And when you see an innominate vein, as I've shown here, which is larger than the ascending aorta, there has to be some reason for this, because the innominate vein is generally not carrying that amount of blood. So seeing a large innominate vein in front of the aorta and the suprasternal arch view should suggest that there's a problem related to this. And again, we can be somewhat relieved from Dr. Rudolph's discussion that the aortic arch appears to be widely patent in this condition, in this particular patient, not in this condition. Now, the supracardiac variety of veins is intriguing from a number of points of view, because venous structures develop, as Stephen said, in situ, and the drainage of the vein, particularly this vertical vein, is critically important in terms of where it goes as to what the symptoms are. In a large majority of them, the vein drains in front of the pulmonary artery or behind the bronchus, and there is really no obstruction into this vein. And here you can see an example. This, I think, is very reminiscent of what Dr. Sanders showed morphologically, with the long right section here, and also the inferior left section here, and the upper lobe here, and they drain up lateral to the main pulmonary artery towards the innominate vein, and then across the innominate vein and down into the superior vena cava, that angiographically produces what we know as the snowman type of appearance. And you can see that suprasternally. You can see it when you look subcostally or subxiphoid here, and you see the whole arch going round the venous structures from the confluence of the veins right through to the innominate vein and down into the superior cava. But in a large proportion of the patients, the vertical vein drains between the bronchus posteriorly and the pulmonary artery anteriorly, creating what is called the hemodynamic vice. And when that happens, the vein gets obstructed between the pulmonary artery and the bronchus. And of course, when that happens, that increases pulmonary arterial pressure. And the pulmonary artery, when it's stiff, when it's hypertensive, gets stiff, and it presses more against the vessel. And often these patients have an episodic course, which many of the neonatologists will attribute to their excellent management as to why the kids get better. I would provide an alternative hypothesis. Is eventually what happens to these patients when they get this pulmonary hypertension is they decrease their cardiac output. When they decrease their cardiac output, their right ventricular output, the pressure falls and they get a little better. And then, of course, then they can get pulmonary hypertension. So they run this episodic course, and I think none of us that have been practicing for any length of time have never been called to the nursery late to exclude pulmonary and vein anomalies because the patients are persistently not getting better. And here you can see on these two still frames here, I think this is a still frame as well, here how the velocity of blood is increasing at the site where the left pulmonary artery is crossing the bronchus, which you cannot see, and giving rise to the so-called hemodynamic vice. And when you get this event, you can see that there is a change in velocity from the left pulmonary vein here to the vertical vein as you see it here. If this was the same color and the same line, we would expect the flow to be the same dark red over here at about 20 centimeters per second. But here the blood velocity is actually aliasing, so it's over 55 centimeters per second. And here is a pressure withdrawal by Doppler taken from a subcostal view, showing the distal flow here and then coming across into the proximal vertical vein here with an increase in the pressure velocity occurring at the site where the left pulmonary artery comes across. And so that's the difference between obstructed veins in this region and the non-obstructed veins, as you can see in this other Doppler example here. And there is just another example of the place where you get the acceleration at the point where the left pulmonary artery crosses the bronchus. Here is an example pathologically of this condition. We're looking from the front, so we see left pulmonary artery. We see the pulmonary vein here and the bronchus, and the pulmonary vein is running between the bronchus and the pulmonary artery and giving rise to the obstruction. This is not the same patient. I just matched this up with the pathological example, showing again the obstruction that occurs with supracardiac veins. And if you look at obstructed pulmonary veins in general, we know almost all of those below the diaphragm have some form of obstruction, but the commonest obstruction is really from the supracardiac veins because they are the most frequent variety of veins. So when you see the pattern that's consistent with obstructed pulmonary veins, don't exclude the fact that they may be supracardiac in their origin. Now, Dr. Rudolph had mentioned that some of the veins that are type 1 drain not to a vertical vein, but to other venous structures part of the superior caval system, such as the azygos vein. And Dr. Rudolph also mentioned, in fact, that this occurs in patients with right isomerism. And indeed, my friend Bruno Marino from Rome has done a series on this and shown that when veins drain to the azygos vein, as you see them draining here, that in 3 of these 7 cases, there was associated right isomerism. And so here you can see the entrance of the vein into the azygos vein with obstruction occurring as the azygos enters the superior vena cava. That's a subcostal sagittal view. And here's the suprasternal sagittal view, essentially showing the same thing from 2 different areas. And I think this is also important in terms of looking, most of these patients are really neonates. But when you look at neonates, is to look at them from a variety of views, because you never know when you're going to see the best picture from which particular angle you approach these patients. So that essentially means you have to do all of them. And I think that in the interest of time, I'm going to move on a little bit in terms of looking at these supracardiac veins. But this is one that drains directly not to the left superior vena cava or to the azygos vein, but to the right superior vena cava. Now, veins may drain directly to the right atrium, and I think this is the important issue. When you see the left pulmonary veins draining behind the left atrium and into the right atrium, you have to think that always the right veins are also going to be draining into that area as well. This is an example of total anomalous pulmonary venous return directly to the right atrium. Not common, but not that rare that we don't see them. And here again, you can see these right pulmonary veins scooting over the back of the atrium here. A color flow will just allow us to look at that, and into the right atrium. And if you go subcostally in these patients here, you can see again that, I'll stop this here and we can just look at this in still frame. Here are all the veins draining directly into the right atrium. The right veins are draining to the right atrium, and the left veins are scooting over the left atrium and also draining into the right atrium. So let me just see if I can get this to play. All right. And of course, we can look at that from the opposite point of view. That's a view of in the sagittal plane, front, back. This is front, back, top, and bottom. And here are these veins coming into the back of the upper part of the right atrium in the region of the sinus intervenarum. Here's a still frame again, one showing the veins draining backwards and forwards. And again, when you put color flow on, I have to say something very important about color flow here. Because venous velocity is low, you have to lower the scale to see the venous flow, particularly when you're looking at flow velocity where it's traveling at an angle not favorable for a Doppler, like parallel to the Doppler beam. Okay, so the next kind of venous drainage is veins to the coronary sinus. I'm indebted to Professor Bob Anderson for the 2 pictures on the left side over here. This is an echo simulated cut of a pathological specimen. These specimens were all put together with crazy glue after have been dissected in the appropriate way and sliced in a simulation of an echocardiographic cut. And I think what's important in looking at this is when the coronary sinus enlarges in this condition because of the flow, the coronary sinus actually enlarges in an antero-posterior direction, so that the left atrium becomes very small and difficult to see, and this may actually almost simulate the presence of a quarter atriatum. From the back, here 2 examples, and you can see here this very, very large coronary sinus with the veins draining into the right atrium. And of course, this is a very easy diagnosis to make echocardiographically. It looks like a whale's tail. You buy the machine that has the diagram put on here. It makes it much easier to recognize. But I think that this is really a very characteristic appearance, and it shows the left and the right pulmonary veins draining together into the coronary sinus and then directly into the right atrium. It sometimes may be difficult to see because the coronary sinus is so large, and it obviously lies at the back of the heart. Here's a sagittal plane, so we have again front, back, top, and bottom. And here you see the coronary sinus running around the back of the heart, but not quite entering the atrium. But obviously, this is a cut orthogonal to this plane here, and you see the coronary sinus very clearly identified at the back of the heart and enlarged to suggest that it's there. Now, here is another example. I think you see this here that is, we said, okay, this is totally anomalous pulmonary venous return to the coronary sinus. But then we examined the rest of the venous structure, and you can see that there's an additional vein that is draining in the vertical direction. So this is where I think you really have to do a careful examination. Otherwise, you land up with the surgeon getting very mad at you because you didn't give him the whole diagnosis. And I think that this is a very important issue because this vein is still salvageable. They can take this vein in the left atrial appendage and anastomose, a nice long anastomosis, and salvage 4 veins in these patients, and obviously give rise to a better prognosis. So this is one of the caveats, I think, in terms of diagnosis that you have to be very careful about. But I think it also points out very clearly the kinds of anomalous pulmonary venous drainage which I showed in terms of mixed total anomalous pulmonary venous return that occurs, that is present. And here's infradiaphragmatic venous return. And I have just 2 pictures here. This is reminiscent of what Dr. Sanders had shown with what we call the Christmas tree appearance. It's an upside-down Christmas tree with no central confluence of the veins here, which makes it more difficult to repair surgically. And this is from the back, so you see the vein going down and enter, let me just say, the porta hepatis rather than being specific about where it drains. And I did find Dr. Rudolph's description so fascinating because in looking at specimens, I think this is an area where it has not been critically dissected. I don't know what yours look like, Steve, but certainly in the specimens that I've come across, I don't know whether people have taken it directly to the portal vein, and indeed whether dissection is really the right way of looking at this. Maybe angiographic demonstration or right, well, maybe a much better way of finding exactly where the veins drain. The surgeons don't really care where the veins drain because they either just ignore it because if they lower the pressure, that's where the flow goes, but sometimes they do, and I think on one of your specimens, they look like there'd been a snare or a little suture placed on that. So that's one of the things that the surgeons do. Here's a different kind of total anomalous venous return. Now, this here, I learned this from my colleague Jeff Smallhorn. This is a suprasternal notch echocardiogram in a patient with infradiaphragmatic total anomalous pulmonary venous return. A cut placed across in the coronal plane, and you can see here the upper veins on each side and the lower veins on each side, draining into a confluence, and this is the level of the diaphragm right here. And then this is the vein going through into the abdomen. So you can see this very clearly. Here's the atrium, here's the aorta, here's the pulmonary artery, and I think that this is a very beautiful example. And again, I think here you see the Nyquist limit is very low, 34/28 peak scale, and it allows you to look at the veins very clearly. Now, my colleague, Dr. Girish Shirali over there, is a big fan of 3D echo, and I think that color flow is a great example of 2D, 3D echo, because where we know that when we look at the azimuthal plane of a scan, that it's very low, and Dr. Sanders showed this very beautifully, how we can now focus on the line of the scan, but color flow cannot be focused quite as well. So if you have a thin scan like this, okay, what you get with your color is something that's much larger than that. And I think I have to caution you about that, particularly if you use what we call color compare. The Philips has a beautiful system called color compare, where you get a black and white image and a color image on the other side. And because we are psychological beings, we like to look at the things that are easiest to look at. And the easiest thing to look at is the color signal. The hardest thing to look at is the black and white signal. So when you do it, you will see, because of it's almost a 3D picture with a color flow, that you may get beautiful color flow, and when you look at the black and white image, you've missed it entirely. So you have to focus your eye on the black and white image, and the color image will be there anyway. So when you acquire the image, make sure you look at the black and white image, and you will have a perfect color compare system on the two sides now. All right, so now we can follow this vertical vein, and this is one of the earliest signs and a simple sign of total anomalous pulmonary venous return. You can actually see the vein running behind the heart here, and red blood flow in a vein going away from the heart is a very bad sign. It means there's pathology. Because when I went to medical school, they told me venous blood went towards the heart. So when it's flowing away from the heart, we got trouble. And this is the vertical vein, draining a nice, fat, plump vertical vein going down to the back of the liver. And this is a sort of a subcostal sagittal plane, and here is a more vertical orientation. But I think that we can see other things here, because we know that the vertical vein may be obstructed at many levels. As Dr. Rudolph had mentioned, within the pulmonary venous tree, down through the diaphragm, and here is it coming through into the porta hepatis, or the left pulmonary vein, and we can actually follow it through into the ductus venosus. I think I have another example that shows that. Now, one of the things that you have to watch out very carefully for is looks like it could be veins to the coronary sinus. Look, here's the whale's tail, but it's further posterior. So, you know, you will see the confluence over here. It looks like it's going there, but it really is going through the diaphragm and requires a whole series of careful evaluations to look at this area. Okay, so that looks like veins to the coronary sinus, and the bubblegram I found since 1982 is a very easy technique, because when the veins on the other side of a capillary circulation, they will not fill with blood. And if you have a circulation of total anomalous pulmonary venous return, if the patient has survived, there must be an atrial communication. So if you give the bubbles, the saline microbubbles will go from the right atrium into the left atrium. So everything will fill except the venous channel on the other side of the pulmonary venous capillaries. So you see very beautifully here how this can be identified, and if you don't have a system that has great color Doppler, that's really a very useful way of telling where they're growing. So here is just another example showing the descending aorta and the vertical vein running in front of it. And remember, the veins come through the diaphragm at 8, 10, and 12. 8 is the inferior vena cava, 10 is the esophageal hiatus, which is also the place where the the veins usually go through the vertical veins, and 12 is where they ought to come through, and your angle has to be a little bit from the right to the left to get all three in together. If you just go straight, you'll see one and then the other, but because they're running in this sort of an angle, you must come a little bit off axis and angle from right to left in order to see them in the long axis as we've shown them here. And then here we'll follow this vein all the way down through the diaphragm into the porta hepatis. And then you'll see even, in fact, that there's an obstruction at the ductus venosus. The ductus venosus is exhibiting, and the left hepatic vein is exhibiting an area of obstruction at that area as well. So we can, find that kind of physiology. Here's this, the portal vein that Dr. Rudolph was talking about. You see here this big dilated entrance here, and then the portal vein going across into the right side. This is the right hepatic vein, and this is the left hepatic vein. Okay, so now here's vertical veins going down below the diaphragm, and once again, not all of the veins are going below the diaphragm. Here's another anomalous vein going above the diaphragm here. So this is another example of mixed anomalous pulmonary venous return. And we don't need those kinds of surprises. Okay, well, we've seen partial anomalous venous return to the vertical vein. That's the commonest one that we identify, and it's got flow in it. And as Dr. Rudolph had mentioned, of course, when the pressure difference between the pulmonary vein and the systemic vein is higher than the other side, there's a preferential increase of flow. This is a child that had a, I'm sorry to show this, Karen, but this is a child who had a ASD repair through a beautiful young lady through a lower sternal incision so she could wear a bikini. Unfortunately, they missed the anomalous veins. And so she came back with persistent right-sided enlargement, and on echocardiogram we actually saw the picture that I showed just now that really was the anomalous veins, and here is the cine CT of those particular veins. And I think that Dr. Hasbani will show us that, you know, it's very hard to compete with the radiological three-dimensional techniques. Okay, so the left vertical vein we've seen. Here is an example again of a scimitar syndrome, and here are the vertical veins draining below the diaphragm here and into the inferior vena cava. And if you've never seen a scimitar, I've just drawn a little picture of what a scimitar looks like. It's a Turkish sword. The condition was originally described by one of Dr. Helen Tausig's associates at Johns Hopkins and called the scimitar syndrome, but that's what had happened. And this patient died with a hepatic necrosis because the surgeon ligated the arterial structure, the extralobar sequestration, right at the site of the celiac, and actually ligated the celiac with it, and the patient died. So here's a scimitar on X-ray, and you can see this very beautifully echocardiographically. The right lower pulmonary vein always runs on the diaphragm before it comes up. Here's the inferior vena cava, and here's the site. This is a parasternal long axis view, and I'll put the MRI into play there, but there it comes with the color flow. You can see the vessel coming in there. And you can see the vessel running down in the sagittal plane behind the heart and into the inferior vena cava, usually in the supra-diaphragmatic portion of the inferior vena cava, as we showed in the specimen. And if you didn't like that picture, I have some others here showing the vein in a coronal plane coming down through the diaphragm and into the vein here. And for those of you that still love angiography, as I do, here's an example of what you can do when you put this into angiographic play. And there is, again, a beautiful example of a scimitar syndrome. So that's a form of partial anomalous pulmonary venous return. Dr. Sanders had showed this beautifully, and I can't emphasize strongly enough how important it is to look at the position of the heart, because the commonest source of mesocardia is Scimitar syndrome. So whenever you see a patient where the heart is in the midline and it shouldn't be there, it should be on the left side, think Scimitar syndrome and start looking at the veins. And here you can see in the subcostal view that the apex is in the subxiphoid space, so there must be mesocardia. And Stephen showed a very beautiful example of this. Here's partial veins draining to the superior vena cava. You see it almost looks like it's coming into the azygos vein. It's not the azygos. The azygos is coming above this area, but it's scooting over the bronchosvascular bundle on the right side and coming into the superior vena cava. This is not associated with the sinus venosus type ASD. Here's another example of anomalous venous return to the right side. I think quite easy to look at when you are suspicious of this and make a point of looking at it. So that's an echocardiographic journey through total and partial anomalous pulmonary venous return. Thank you for your attention. Dr. Basbani? Oh, yes, of course you can. Here, I'll just do this here. I'm sorry, I forgot you got a Mac. How could I forget that? Okay, here, we put the power cable in first. Okay. Perfect. And perfect. And
yes, perfect. Just take care that it is not scratching at the cloth, but
it's okay.
it's okay.
Good morning. So anomalies of the pulmonary venous connection. We started talking about cardiac MRI yesterday, and I'm going to review some of the stuff as we go through it and introduce a few more techniques that I didn't go over in as much detail yesterday. As I was telling you yesterday, the key part of cardiac MRI, besides the intracardiac anatomy, is really the extracardiac anatomy. So the IVC and SVC, as well as the pulmonary venous, and then also the great arteries, the pulmonary arteries, as well as the aorta. So today, or this morning, the pulmonary venous return will be discussed. They're relatively rare, but echo, as we've seen, CT, and radiographic VQ, or ventilation and perfusion scans, play a big role in looking at the venous connections. The pulmonary venous connections by cardiac MRI, really, it's a special way to look at them that will provide, regardless of the orientation, the flow, the anatomy, and if needed, it's in a non-invasive without radiation. So we're going to look at it by the cine, so very similar to the 2D echo, but then we can also look at it by MRA and 4D flow, and I'll show you the 4D flow, which is a really beautiful way to look at it and color coordinate the deoxygenated and oxygenated flow so that the surgeon can see that, and then the velocity encoded. So we'll start with the velocity encoded. As I mentioned to you yesterday, this is similar to what we call color compare echo. You have your anatomy on the right, up here, that's been labeled for you, and then the velocity encoded image, which is going to be black and white. So you can see the aorta here, the SVC, the pulmonary veins, and the right pulmonary artery in this sort of configuration. And then you can draw circles around the anatomy that you're most interested in and get a flow of it, looking at the pulmonary artery versus the pulmonary vein and see if it's a normal or abnormal flow that you're getting through it. So here's an example of a MRA, and here you see the pulmonary arteries, the left atrium, the right atrium, the IVC, and here you're seeing the pulmonary veins. You've got your left lower pulmonary vein, your left upper pulmonary vein, which you see is a bit smaller, the right pulmonary vein, and then the scimitar vein that's coming in through the IVC into the, through the pulmonary veins coming back to that and then coming into the right atrium. Here's a very well recognized scimitar vein showing you how the abnormal pulmonary veins are draining into it. And this, as Dr. Silverman noted, can often cause the heart itself to be either mesocardia, or in this specific situation, it's actually dextrocardia. And you can see that the left lung is quite a bit enlarged compared to the right lung, and that's what's pushing the heart actually into the wrong location. And you can see that all throughout, even in the four chambers. And in this specific patient, you can see that the right atrium and the left atrium are both dilated, and there's actually even hypertrophy of the ventricles from the pulmonary hypertension. This is a patient that has scimitar. Here's the scimitar vein. And this is the 4D time resolved. So you'll see when I start playing it, you'll see the images actually showing up. And here it is. You can see the blue and the red coordination with the purple showing you where the abnormal flow is happening and where the well-oxygenated blood coming from the pulmonary vein is joining in with the IVC, mixing in the right atrium before it actually enters into the right ventricle. So SVC right up here, IVC down here, and right pulmonary veins, oxygenated blood joining in into the right atrium and then entering into the right ventricle. So especially right here, you can see that causing the scimitar vein. Here's what would be the scimitar vein. So again, everything labeled for you. So this is a nice way to show how the flows are abnormal, showing your surgeon where the abnormality occurs, and so the surgeon can go in and then ligate and redirect the correct location. Here's another patient that has congenital stenosis of the left pulmonary vein. And you can see that both the left upper and the left lower pulmonary vein are stenotic at the actual junction into the left atrium. You can see the left pulmonary artery is significantly smaller than the right pulmonary artery from the decreased blood flow. And you can see how decreased the blood flow is, the right pulmonary artery versus the left pulmonary artery, and the abnormal pulmonary vein flow. This patient underwent surgery, which, as we've heard, is not always helpful. And in this patient, the left pulmonary artery has gotten even smaller after surgery. This is 8 months after surgery. And the left upper pulmonary vein and left lower pulmonary vein remain stenotic and have not improved. It actually now has reversal of flow in the left pulmonary artery, showing you that it's gotten worse. And the left pulmonary veins have got almost no flow through them. So this is a patient who's had surgery with minimal improvement, if anything, actual probably worsening, not because of the surgery, but the actual pathology that's continued to happen. Here's another 2 different patients that have pulmonary, partial pulmonary venous return. And you can see here, this is the SVC. Here's the aorta. SVC innominate, and you can see the left lower pulmonary vein is returning into the innominate vein into the SVC abnormally. Same thing here. Here's the aorta very nicely. Here's the pulmonary vein coming back to the innominate into the SVC abnormal. Here's another one, pulmonary veins again. This is actually a CT coming into the innominate into the SVC abnormally. So cardiac MRI can help you looking at the venous connections. It can also help you do a QPQS, or a left pulmonary artery versus right pulmonary artery, depending on whether you have a partial anomalous pulmonary venous return. It helps you with the anatomy of the pulmonary veins, and it can also help you with follow-up on patients that have had pulmonary vein stenosis and have undergone surgery. All right. Go ahead.
I just asked, how long does it take you to do cardiac trace pictures, and do you do that often for the surgeons? Do you use that frequently with these patients for surgery?
So it depends on
Show the flow.
the 4D flow, or you're just saying the velocity encoded flow?
So the reconstructions that you have.
So the reconstructions, the actual time it takes to acquire the images is not that long, 10, 15 minutes. Doing the color flow is actually quite extensive and takes a long time. And it depends very much on the surgeon and the patient's size, and whether the surgeon feels that they need that before the surgery. But yes, that is definitely time consuming in the post-processing. So the patient time on the table is not significantly increased. But yes.
How often do you do that?
Not often. Yeah.
You're really on the pictures.
Yeah, thank you. But yes, we don't do that often. So it's definitely much more in the research realm of doing that when you're trying to figure out research patients. But yes, you're right. It's not used often. Any other questions?
I have one. Dr. Rudolph would like to finish his discussion. Is that okay with all of you? Great. Please, Abe. You said you didn't need the computer.
Then I stopped because I thought I was spending too much time. What I really wanted to do is we talked about severe obstruction. And I'd like to mention a few points about
May I give you a microphone?
obstruction. Because this is a common problem. And what happens is that this is particularly true of patients who have drainage into the superior vena cava through a vertical vein. And what you see is these babies do reasonably well in the initial period after birth. And then several weeks, even as long as a couple of months later, they begin to get respiratory distress and evidences of pulmonary edema, clinical evidences of pulmonary edema. And it comes on slowly. And what you usually find in these patients is that when we used to do catheterizations on these babies, we used to find that when we passed the catheter through the superior vena cava and across the innominate into the vertical vein, that as you withdrew the catheter, you found a pressure in the pulmonary veins which was up as high as 15 to 20 millimeters of mercury, which is quite high. And as you pulled it back across to the superior vena cava, you found that pressure drop fairly rapidly. So that what these patients have is they have a small channel, and it's not a specific site of obstruction, it's just that the channel is small. And what's happening with these patients is that as pulmonary blood flow gets higher, this becomes more and more significant as an obstruction, and as the baby is growing, they have a higher pulmonary blood flow and they begin to show evidence of obstruction. And it's really interesting because it's quite a common presentation in these babies. So I just wanted to point out this issue. The second important issue is we mentioned that all the systemic blood flow has to be derived. I'm being told to hurry. All the systemic blood flow has to be derived across the foramen ovale. Now, early on, the total output is not that high. You know, it's just a normal output. But as the baby's growing, the pulmonary blood flow increases, the output requirements get higher, and at that stage, the foramen ovale may become restrictive because you need a higher and higher flow to sustain systemic output. And that is when you may begin to see evidence of right-sided failure as well as left-sided failure, because when right atrial pressure goes up, pulmonary venous pressure goes up because they're draining into the right atrium. So that when you get to, it varies several weeks, a couple of months after birth, you begin to see evidence of right-sided failure, and it's because foramen ovale obstruction occurs. And in Houston at one time, because they noticed this, they used to routinely, before they were operating on patients with total pulmonary venous drainage anomaly, they used to do an opening of the foramen ovale to try to avoid that from. That's all I want to say.
Not okay.
Not okay.
No. No.
I would think that they shouldn't have a gradient at all.
Right. Now this is at the anastomosis of the atrium, so it involves all the veins.
Yes.
Yeah. No, I think something can be done about that.
Yes, I think so too.
Yeah.
That's good to ask you. So I will send a
Or send her someplace else if they're not willing to do it, because I mean, I think this should have been done some time ago. I bet she has mild pulmonary hypertension at this point.
Yeah.
I usually this can be corrected either with the sutureless approach that I was talking about, the Francois Lecour-Gaillet approach, or even just, if it's really at the anastomosis, you may not even have to go out into the pulmonary veins. You can just put a patch right across that area, or even resect some of the material that's inside. Some people have used stenting in this. I'm not so enthusiastic about that. I think you probably could do better with surgery.
So I will talk to the multi, because I'm not.
Yeah.
I always have because it was.
Yeah, no, I agree. I think
that's
not a good result.
No, it is not. And they said because it was just